Well, welcome back, Dr. Geyer. We're so happy to have you here again talking with us. We really are so excited about you joining us for this five-part series dedicated to helping hospitals and health systems build an opioid stewardship program. In the first episode, we talked about the fundamentals of good opioid stewardship. In the second episode, we discussed the importance of investment, leadership, buy-in, frontline voice of the customer participation, and really the importance of teamwork. Today, what I'd really like to talk about is the medical community's impact on the opioid crisis and really how we navigate the sensitivities around merging state and federal requirements, national guidelines, and other institutional or community protocols that are out there for opioid stewardship. From a practitioner perspective, it seems there's so many pieces to juggle and so many things to put together in order to really provide that best in line practice for the patients and families we serve. And I know that even in the field, some of these early practices and these early guidelines may actually have fueled the epidemic in some ways. And so I really would like to talk about those things. Maybe we could start just a little bit with a reflection back and a little discussion of the history about the opioid epidemic and how we've gotten to some of the regulations that are now in place. Holly?
Thank you, Maria. What a great chance to be with you today. I'll start off with this. I am no historian. I'll be the first to say that. But even someone with my limited interest in the topic can find the irony of the opioid epidemic of, interest. And I would say, the field says that hindsight is 2020. When it comes to this topic, hindsight really brings us back to 1890 or so. The history of the opioid epidemic is really 100 plus years for America. This is not just, the last 20, 30 that we've been dealing with this problem. And as we look for the sources, there's going to be really one clear conclusion that comes out of this. None of us are as guilty as all of us. When we look at history, it's not just a medical industry problem, but it's been one that's been fueled and owned by the community, by the government, by insurances, by patients, by patient families. There's so many elements where we all could have done better, all could have contributed. And so, from my perspective, I think the best way to look at where we could go forward is to understand where we've come from. And America can trace its opioid prescribing roots all the way back to the 19th century. We saw drugs like heroin and morphine and cocaine very readily available in the community. And that's because there wasn't a whole lot of caution and almost no regulation over the use of this stuff. Honestly, nobody needs a PhD to guess where Coca Cola derived its original ingredients, right? And the original real symptom relief in Bayer aspirin was heroin. So you're kind of getting the picture here. But between the 19 teens and the 1920s, this is when the medical community started connecting the dots, shall we say, between opioid use and then addictive behaviors and overdoses and all these other consequences that we're seeing today. And this revelation started prompting the crafting of what became the Harrison's Narcotic Act of 1914. And this is essentially the first big regulation over opioids by the federal government. It taxed opioids, it limited who could prescribe them, and really got a lot of them off the streets, which was good. But kind of fast forward through the 1940s when people started receiving opioids, primarily morphine, for war related issues and developed opioid addiction from that. And then all the way to the 1970s, when we started seeing kind of the same stuff from the Vietnam and then the Korean Wars. Addiction was prominent, and the Controlled Substance Act was released back in the 1970s. And this was pretty much the big effort on behalf of the federal government to control the production, distribution, and possession over all controlled substances. And out of this, we also saw the creation of the DEA as more of the enforcement arm. We also start seeing some pivotal uptrends back in the 1970s and 80s in heroin use and ultimately overdoses. Now, we knew heroin caused problems, right? And it's an illicit opioid. But ironically, despite being ostracized by the medical community and fully recognized that it caused problems, at the exact same time, we see this paradoxical embracement of pharmaceutical grade opioids. And as we move into the 1980s, there's this 100-word, not page, mind you, word article written in the New England Journal of Medicine that summarized this retrospective evaluation of about 11,000 hospitalized patients within this healthcare system. And the authors concluded that, hey, good news, there were only 4 cases of addiction that had reasonably occurred amongst those 11,000 individuals that received prescribed opioids. Fantastic, right? Now, for many listening, they realize the irony of this. In today's scientific environment, a commentary of this limited structure wouldn't stand a chance at first editorial review. But for reasons we may not understand, this publication actually became one of the biggest stepping stones to deregulation of opioid prescribing in the entire history of opioid prescribing. In fact, data shows that article was recited more than 600 times as of just a couple of years ago. The vast majority of uses of that article was for promotion of pharmaceutical grade opioids and opponents saying it offers very little risk of addiction and overdose. So then we start seeing this concept of pharmaceutical opioids being safe gaining traction. And from the 90s to the early 2000s, there's this parallel campaign to treat patient pain to the satisfaction of the patient start to emerge. And I will say the combination of those two topics was cataclysmic. Just to give some examples, between the 1990s to the mid 2000s, first we have pain becoming the fifth vital sign turn into a campaign. And any of us who know how to take a pulse realize that this is the only subjective and unverifiable but actionable vital sign on the market, right? Someone paying Candy Crush can have a 12 out of 10 pain, and someone who's chopped off a limb can complain of a 3 out of 10 pain. And at the same time, we've got the Joint Commission publicly claiming that there's minimal evidence to support addiction as a significant side effect of opioids when used legitimately for pain. And ultimately, they use that logic to require providers to assess pain on a regular basis. And this includes in populations that may not necessarily have solicited the symptom. So when you're asking anyone anything, there's a chance they might respond now that they think about it with an answer that yields a positive result. And then at the same time, we've got practice reimbursement being linked to patient satisfaction scores. And this creates this dangerous situation where we've essentially put the patient in the driver's seat when it comes to pain management decisions because there's income associated with positive or good control of those symptoms. And then at the same time, the doors were opened up from a litigation standpoint for physicians to be sued by patients who felt their pain was being inadequately controlled. None of us want to be sued. And so a lot of us were scared into treating, again, to patient satisfaction, not necessarily functionality. And at the same time, all of this is going on. We've got this heavy marketing going on by pharmaceutical companies showing us the safety profile of these novel opioids that were brand new on the market, despite now that we've got better evidence out there from court trials and documents showing that they actually knew overdoses and addiction were serious problems with these novel agents. So you put this all together, Marie, and you've got a recipe for a drug epidemic, and that's precisely what it became.
Holly, that is just amazing. I love to hear history in healthcare and hear those stories. I always think about Florence Nightingale and infection prevention and all of those things. That you just presented an amazing history and linked things in a way that really helps understand what we're dealing with and why we're dealing with it, right? So many times we don't know the why, we just know what's in front of us. And I think having that history that you just shared with us really hit on all of those touch points that brought us to where we are today. I think that's so important for the understanding. There's so many different unintended consequences with what you just described, things that we didn't necessarily think or would happen or plan to have happen that led us to this really this culture we have now around addiction and pain management, right? That's the other thing. I think part of it is our society expects us not to be in pain, right? We shouldn't have pain. Well, I'm getting older and every day I know there's a little pain there and that's okay. It reminds me I'm still here. So, so I think that culturally we have to become more understanding of what pain is. It's a signal and what do we do with it? So really that history was very helpful. I understand that there's also some good news that, and correct me if I'm wrong here, but the data is showing that opioid prescribing is on the decline. But with that being said, the number of opioid related deaths is still staggering. The CDC is predicting that 98,000 overdose deaths from February 2020 to February 2021. And I know we're lagged on those data points just a little bit. But from your perspective, what's not getting fixed and what needs our immediate attention? What do we have to do right away?
What a good question. And I had seen a poster a couple of years ago, and it was by a company, and it said, if you thought your problems were bad, just wait till you see our solutions. And truly, that's one of the issues that we've seen come out of management of the opioid epidemic. And I think we need to take ourselves back to that 2010 to 2015-ish timeframe. We knew we were getting into problems as a medical field. We've seen some trends where, individuals who receive opioids are more likely to develop addiction. We're seeing some overdose problems up to 2010, 2012, and providers were catching on. And because of this, they start publishing. And this is how we get our word out in our world, right? The publications that were coming out in the medical literature were showing national trends that were of concern. And we start seeing a deep prescribing attempt by the medical community right around 2012. In fact, there was a study by the AMA that reported a 37% decrease in opioid prescriptions. That's an estimated 90 million prescriptions just from 2014 to 2020 in attempts to, really bring down these overdose numbers. But with all this, we saw this paradoxical effect in many communities. In fact, now it's a national problem. Instead of seeing reduced overdose deaths, they're going up. Deaths involving prescription opioids reduced from 12,000 in 2015 down to around 11,000 in 2019. And yet, deaths from synthetic opioid increased from about 5,700 to 36,000 during that exact same time period. So we know there's a lot of contributors to this. And I think one of the most likely ones is that patients that had chronically been receiving opioids from us in the medical community were developing dependency and then ultimately opioid use disorder on them, whether realized or unrealized by their providers. So as soon as we start to cut back their healthcare supply chains, they turn to other sources, street drugs. And keep in mind, these street drugs, there's no quality checks, there's no standardization, there's no main dose, there's no monitoring in place. Half this stuff has flour or talc or other substances mixed into it. And these drugs just became natural killers. A study by the DEA that just came out recently showed that 42% of all confiscated pills tested for fentanyl contained a lethal dose. And so the government's watching these disturbing trends, and we see this host of state and federal responses emerging, mostly around that 2015 and 16 timeframe. And I would say it's really these responses that have built the frameworks for the best practices that we see in opioid stewardship for program monitoring. Many have been partnered with medical society recommendations and just this eruption of medical research on the topic of opioid stewardship. So I would say, Marie, there's no doubt we probably have more tools in our hands today to get this right than we've ever had in American history.
Wow, Holly, that's amazing. And as you were talking, I thought exactly what you said, that as we've restricted all these things inside our walls, we have driven people to the community, to the field to close the gap. I mean, pain control and limiting pain, right? Taking care of acute pain is probably one issue. Taking care of chronic long-term pain, we have an aging population. There's a huge gray tsunami coming. The longer we live, the more things we have that may, cause us to have pain. So it seems that, dealing with those two things is really important, and how we do that without pushing patients to the field, as you said, where, when you buy something, there's no prescription with it that tells you how to use it or what to use it. There's no quality control on what you get in the field. And that's just frightening and very sad to think that, patients who are really have to deal with pain are pushed to that because they don't know what else to do. So, how do we improve policy and practice guidelines? Talk a little bit about policy and practice guidelines, and what do we need to know as healthcare about those things so that they become useful tools instead of a negative burden on the practitioners that are trying to provide, the best care possible. That's the goal for most people who go into healthcare. So help us understand a little bit about how to improve the policy and practice guideline arena.
Great question, Marie. And there's so many aspects to address when it talks about, or when we talk about what the best way to make this the least onerous on the practice while the most impactful to patients that it can be. And I think from my perspective, as we start designing these, it's going to be key to really understand how we sell this, how we sell it to the patients, how we sell it to the practice. And to do that, we really need to make sure that we've got the what, the how, and the why of prescribing ready to go in our back pocket. As you talked about, the what is going to need to be building out those acute and chronic prescribing guidelines, all of the patient screening protocols before we prescribe. It's going to be key to define which populations are appropriate to receive those opioids and have Narcan policies in place. Documentation guidelines, how are we going to chart all this? And then what are you going to do with patients that have behaviors concerning for opioid use disorder, as well as institutional monitoring of all of this? The how, we're going to want to focus on communication strategies, right? We need to keep providers educated on these protocols, the state requirements, and then make sure that we're also communicating all of this to patients. At the end of the day, the patients are the end users of all of this. And so making sure that they are at the table instead of on the menu is going to be key. Creating educational handouts and forms can be very helpful to standardize how that message comes across. I would say, Marie, though, the why ties this all together. And no matter who your audience is, it's going to be critical to stress that the point of change is to improve care and stop needless and preventable consequences. So use those numbers to drive home the concepts. When we put this all together, making this, the least challenge to the practice and the least challenge to the patient requires cooperative effort and then ongoing reassessment of whether or not your interventions have been impactful. And again, that comes back to the concept of quality. If programs are housed under quality, I think there's great opportunity to partner and piggyback off already proven mechanisms to make this happen.
I was just going to say, this sounds like a PDSA cycle, right? No matter what your quality methodology might be in your organization, it comes back to Plan, Do, Study, Act, or doing things, making rapid cycle changes and measuring, monitoring your results, and then changing things as needed going forward, which is just fabulous and really important. The what, the how, and the why is a great way to think about what we do with policy and practice guidelines. How do you keep up with changing regulations? We talked about so many different organizations that might be impacting regulations or policies. Who's kind of the key, or is there a key organization that you follow? And do you have any processes in your practice around how you kind of get updates and keep up with the changing regulations so that you can do that PDSA cycle and really look at what needs to be monitored and what's changing?
Very good question. One word comes to mind as an answer: standardize, standardize, standardize. Standardize your workflows, standardize your metrics that you monitor, and standardize the group of people that can help keep you in compliance. And that's what we've done. It takes a partnership. My life is busy, and running our opioid stewardship program here is just one of the many hats I wear at our institution. And so I don't know where I would be without my administrative partner. She's a pharmacist and she's brilliant. I don't know where I'd be without accreditation coming to our regular meetings, or our regulatory team, quality and legal, that sit in on these regular meetings. They really filter down the changes coming from regulatory environments. So those under Joint Commission, those coming from CMS, they're able to bring those to our attention so we can act on them. And then at the practice level, we did create something called opioid liaisons, which I believe we'll be talking about in a different lecture. But opioid liaisons are individuals embedded within our practice at each division level who stay in close contact with their division leadership and monitor internal metrics. And they have been so key to helping us develop individualized practice changes that need to take place without necessarily impacting other fields that wouldn't agree with the changes or wouldn't be appropriate for the patient population they treat. So it's been everyone coming together at the table and making sure that we perform all activities in a standardized format.
That's great, Holly. That's really that's excellent information. So, Holly, you've given us some amazing information over these sessions, and especially today. If somebody in our membership or someone listening in the audience today really wants to get started and get some information on how to build a successful opioid steward program, is there somewhere that you would recommend that they go to just kind of get started?
So absolutely. The best place that I could recommend to really get a good overview in more of a handbook format is exactly what you do, Marie. The AHA Opioid Stem the Tide Toolkit. is going to be a key reference for individuals. I would recommend going to the website and downloading a copy of that, which will give you a high level overview of kind of the next steps for everyone. From our institution standpoint, we started off without that resource because it wasn't in existence. And we really needed to start with what are state guidelines, what are federal guidelines, are we using the PDMP appropriately? We had to keep an eye on CMS, make sure that we were following all the recommendations going on there. And then there's federal guidelines from the CDC. As many may be aware, the 2016 guidelines are in the active process of being updated. And we hope either by the later this year or early next year, the new guidelines will be released. I have had the chance to review those, and they're very much in line with current practices, with perhaps a bit more openness to how we treat patients with chronic pain, making sure that the treatment is individualized. Of course, you're going to want to tailor all this information down to your practice, to the field, and to your specific patient populations. The American Academy of Pain Medicine, AMA, American Society of Addiction Medicine can be incredible resources as you go through that process. And then look to division and department leaders to see if their particular medical societies have tailored resources that can help address stewardship as well. For many of our listeners, it's key to make sure that you're looking at institutional requirements if you are part of a larger organization. That was key for us at Mayo, considering our size. And then ultimately, make sure that you've got legal's opinion on how you're managing this. I will say that I had put forward a number of suggestions that were shot down by legal faster than you can imagine because they weren't necessarily meeting the muster of the organization or would be within what we considered our own internal safety guidelines of legal practice. So all of these are going to be key opinions and places to look as you move forward on this journey.
That's super helpful, Holly. Thank you. And it sounds like you have become an expert in so many fields as you've gone through this legal and pharmacy and nursing and all of the pieces of the village that it takes to really do this work. The other thing that I would think is that other organizations, yourself, organizations that have done this work, one of the things that we really try to encourage and help our members do at the American Hospital Association is to share case studies, learnings. The podcasts you and I are doing on this topic, Holly, really is a way for us to help members learn from other members. And it is really one of the biggest strengths that I think our healthcare system has, and that I see such a willingness, as you are so willing to share your experience, sort of the good, the bad, and the ugly of doing a large implementation like this and really changing the culture that is around opioid use in our communities and in our nation today. So thank you so much for that, Holly, for being willing to step up and to spend the time, which I know you don't have much of. So taking the time to spend with me and have this conversation, we very much appreciate that. And then I would just ask you, as I have before, for any last minute pearls of wisdom, or as I heard someone say not too long ago, stones in your shoe that just bother you every day that you want others to be aware of.
Oh, thank you, Marie. I so appreciate the opportunity to talk to the broader medical audience. If I could ask one thing of our audience, it's to take these concepts and remember that these are people's kids. These are your kids. These are my kids. What was once something we've historically put to the side as a rural problem, as that of, socio or demographic features we interact with on a rare basis, it's happening in our own backyards. It's happening in our high schools and our junior highs. So if there's going to be a generation to stop this epidemic, let it be ours. And it's going to start with opioid stewardship.
Holly, those are amazing words to end our conversation on today. Thank you so much for sharing your experience and the change going on within your organization.
Thank you, Marie. What a pleasure to be with you.